stakeholders sometime in 2018, and then evolved into creating this nonprofit. And our goal is to create opportunities for training and to further integration of behavioral health into primary care in Arkansas. So I'm going to go ahead and share my screen and just get going. If you have any questions, please feel free to type them in the chat. There may be times that I'll say, hey, if you'd like to interrupt me, feel free. But we definitely at the end want to have some discussion about where we might go from here. And part of why I was wanting to talk about psychiatrists, we've been putting together pieces of behavioral health integration across the country and in Arkansas. And one of the big pieces is, where are all the psychiatrists? And we're needing to get psychiatrists plugged into behavioral health integration more, as well as primary care doctors. So this is a big piece, and so we want to take time today to talk about that. We'll talk some today about what's the need, why do we need psychiatrists, why do we need behavioral health. We're getting, people are getting more used to that idea, and we'll talk about some of the COVID data and talk about the specific statistics around psychiatrists, the shortage, and where's the system, and get some ideas about what approaches that we might use as we go forward. So psychiatrists, if y'all heard me talk before, I love this slide. And so I tend to want to show it because what is a psychiatrist? Recently, I filled out a form and it had 3 check boxes. It was for a medical doctor, a psychiatrist, or for other. And so often people don't appreciate what a psychiatrist is, that we've actually been to medical school and that we're a physician. And then what do? There's kind of a mystery there. And what psychiatrists think they do, it's got a picture of Freud. We think of ourselves as being able to provide more than what the system at this point wants us to do. And that is, you see the Prozac pills. Psychiatry has evolved into being prescribers. And one of the things that's frustrated me the most is being called a prescriber. I understand at times with language in terms of clinicians are often being called providers, which to me, one of the most sacred parts about being a physician and being a healer is the relationship with patients. And that's so being called a provider and someone being called a member, I know that's some of the insurance language, but it's the relationship where healing happens. And it's the relationship in primary care where a lot of healing happens. Our medications and our treatments are just one piece of what we can do. They're tools, but it has to do with that relationship. And so to me, we are much more than prescribers and the pills that we can prescribe or that we can give. That's just one of the tools. So who are psychiatrists and what do they do and why do they do it? There's some things to think about in that as we move forward. This slide is about actually a story of 2 different psychiatrists and outcomes. And it's relevant in terms of talking about psychiatry and the effect that this work can have. But also it's relevant for, just human beings who are struggling. And the psychiatrist in the upper left was in residency and a single mom going through a divorce, struggling with the challenges of the work, but also struggling with challenges of being a parent, income, the stress of interpersonal relationships. And I know that this person during their residency actually went to the residency director and said, I think I need to resign. I think I need to step out and take a break. The residency director and didn't say why, but the residency director said, no, that's not going to happen. Let's see what we can do to adjust. And during the period of being a resident, then that resident didn't even consider going to see a counselor or another psychiatrist, even though it was a lot of struggle, but had colleagues and actually a mentor psychiatrist that was able to say, hey, let me go ahead and prescribe you some medication, and started this resident on an antidepressant. But also this resident happened to have a supportive family, friends, church family, and was able to work through all that, never considering going to see a psychiatrist or any formal mental health training, but was able to graduate and move forward and have some success in career, as well as deal with all of those things. And I know that resident well, because that resident is me. And that's something that I went through, and I knew how I felt then, and I know how I feel now at times. Mental health people and professionals, physicians, people don't want to go see psychiatry. There's so much stigma to saying, yes, I struggle. It's okay for us to help other people, but for us to get help ourselves, or when we renew our boards every year with the licensure board, we have to say, do you have a mental health problem? Are you getting some help? The stigma of getting help is huge, and that's relevant for all of our patients who are struggling and who may be going to see their primary care or maybe not. Now, this other resident in the right-hand corner was a resident at the same program 2 years before I was there. I don't really know the story. I know that she was struggling. 2 years later, they said, yeah, she was kind of strange. She was really irritable. She was grouchy. But all I know is that someone found her and that she had taken her life, that she'd had an overdose. I don't even know the story. Now, this is 2 years later in the same residency program, and it was so significant that this young lady took her life, but they didn't even teach us about it. They didn't even know, we don't know what happened. And so this life or death thing happens, and so often people, patients are walking around, you don't know what's underneath it, and people get very desperate to the point that they end up taking their lives. And it's really sad. Actually, recently we've had suicide of a physician in Arkansas, but we don't talk about it because there's still so much stigma. And the stigma also is going to affect our patients who are trying to get help in primary care. And that's one of the huge barriers that we're having issues with trying to make headway to improve outcomes for our people and for our patients. In mind, as you're thinking about a psychiatrist, but also thinking about the people we're trying to help every day. I wanted to point out the making of a psychiatrist. I was mentioning that not everyone realized psychiatrists have been to medical school. And it's an important piece because in learning and becoming a psychiatrist, you go to college 4 years and you go to med school. All physicians get to that point, and all med schools at this point usually have a course in the second year of med school on behavioral health. Then usually during the third year, there will be anywhere from 1 month to 2 months in psychiatry. It's mostly spent on the inpatient wards. And that's where most physicians get their training in psychiatry or mental health. And then at some point, if someone is going to become a psychiatrist and they know at third year, they may do an extra rotation in fourth year. But if someone chooses not to do psychiatry, they may never get any more mental health training, formal training with psychiatrists in medical school, if they choose something other than psychiatry. So then we go to residency. And if you're in psychiatry, it's a 4-year residency. Family medicine, I believe, is 3 years. Surgery, maybe 5 years. If someone wants to do a fellowship like child and adolescent, it's another extra year, addiction psychiatry, and some of these other specialists. So that's the pathway to becoming a psychiatrist. And a huge portion of training is on general medical care. But then once you get into residency, there's just 4 to 6 months on general medicine. So oftentimes there's even a bigger divide in what a psychiatrist knows and is used to doing. And there's a big divide on what other physicians learn. In family practice, residents may get a little bit of formal training in psychiatry, but a good bit of it, even though the family medicine docs and pediatricians are doing a huge amount of mental health care, they're getting it kind of as they go in their rotations from their mentors who may or may not be psychiatrists. And this is part of why we're struggling with taking care of mental health issues for people in our society, is the training in medicine. And so not only is it in psychiatry and medicine, but even in nursing or all types of healthcare, people are going along in their training or in their lives, and there's a fork in the road, and it's, are you going to take care of mental health problems? Are you going to psych, or are you not? And there's a fork in the road, and sometimes it doesn't meet again. And, the psychiatrists are over on one side, or the therapist, the nurses may choose to do psych or not psych. And what we found as we tried to implement behavioral health in Arkansas is that we're telling our primary care colleagues or specialists, okay, now be sure to assess people for depression or suicide, and not realizing that everybody that's in medicine came to a fork in the road and said psych or not psych. And if they don't, and a lot of times people will choose not psych because they've had some issues in their own lives. They may have dealt with a family member. They may have decided, that's just something I'm not going to deal with. And so they choose not psych. And it becomes a huge challenge when we, or whether it be the CPC Plus program or ACO, or just trying to be general good caregivers, and we need to assess someone's mental state, but we chose the other fork in the road, and then we also didn't get the training if we didn't choose that. So this divide is a huge part of the issue of people trying to get help and get better. And so the problem that we have, these statistics, you all could give better than me, but they're a huge problem with mental illness and mental issues, not even disorders, of people who aren't getting help. So at least 20%, 1 in 5 adults has some form of mental illness. And when we say the word mental illness, we also mean, quote, just depression or just anxiety. But 60% of those who have some symptom or disorder are getting zero treatment. 60%. They don't want to go see a psychiatrist. Even psychiatrists don't want to go see psychiatrists, much less go see a therapist. And especially if someone's functioning well or functioning a little, they don't feel like they need to. It's a last ditch thing. There's often a huge delay in the time somebody gets symptoms before they ever get help. And it's just when it gets fairly desperate. This has cost tons of dollars in our society, to people not being able to work, but also the decreased function on the job. And then you can see, even in 2016, a huge amount of our U.S. healthcare dollars are spent on mental health disorders. So in Arkansas, actually, and this was a few years ago, 2018, probably, the statistics show that suicide was the 10th leading cause of death in Arkansas. It's going to be around that in most states, but even these data from Arkansas, that there is a suicide in Arkansas every 14 hours. There's 4 times as many suicides as there are alcohol and motor vehicle accidents. And the significance of this is that many of them are not recorded as suicide. The person I was speaking of earlier, it was recorded as a cardiac arrest. So suicide is something that we have got to get under control, and it can, and there's a lot of talk about it, but trying to continue to figure out the different ways for us to work together. That's one of the reasons we're excited in ABIN that this grant that we've got is about how to do suicide management in primary care, not just recognizing it, but how we can manage it. And we've got a fabulous trainer that can give some really practical tools. The other huge thing we all know about opiate use and the increasing problems that we've got with that and the deaths. And some of these are intentional overdoses, but a lot of those are not intentional, but they are often going back to mental health or anxiety and depression. Addiction doesn't just occur. There's usually something that started the use of these drugs or medications. These, not only we had these issues before, but now that we have the pandemic and COVID, New England Journal of Medicine and JAMA, Journal of American Medical Association, these are general medical journals. Of course, JAMA Psychiatry, this article on the 2019, the perfect storm of suicide and corona. And then the New England Journal of Medicine, that just came out August 6th, the mental health, how COVID and the pandemic is affecting mental health. You can't even hardly open Facebook or get on email without seeing how things, this pandemic is making things worse. And this is a CDC report, and actually I forwarded the report to you all in the invite from yesterday, and you can read it in more detail. But you can see that June 24th to 30th, this was an online survey to 5,000 people. And I've got the yellow is all the respondents, and the green are the people from the South. So it's 35% of the people. And anxiety symptoms, 25% of people, this is in June, reported anxiety symptoms. In the South, 27.9%. Depressive disorder of all, 24%, and 26% in the South. Either anxiety or depression, almost 31%, but 33% in the South. The COVID-19, that's a related trauma symptom disorder. So with COVID, and the article goes into some of the different things. Was it related to having someone in their family, or what is this bringing about? But you can see the people in the South, almost 30% of people are having some issues. This is bringing up issues with trauma, whether they had trauma in the past or this is traumatic in some way. Very relevant that 13% of all respondents are saying that they started or they increased their use of substance use, it's maybe alcohol or other substances, to cope with the stress related to the pandemic. In the South, that's 15%. The article's interesting because it goes into how actually employed people and essential workers, this is even higher, surprisingly, than in unemployed. And in red, 10% of all these respondents reported seriously considering suicide in the past 30 days. And in the South, that's 12%. So almost 41% of people reported at least one mental or behavioral health symptoms, and that's 44% in the South. So this is significant. And just like the psychiatry residents who are walking around, they understood psychiatry, they weren't about to go get help. Most of these people either don't have access to getting formal mental health treatment, or they're just not going to because of the stigma and the barriers that we have. So this is some of the state of where we are now. This slide, actually, one of my colleagues from Evolve MD sent this out on the Collaborative Family Healthcare Association listserv yesterday. And if you all, any of you are interested, are doing behavioral health integration or want to know more about it, CFHA is a great organization to give information and practical tools. So he sent this out yesterday and gave me permission to use it, but he summarized the CDC article and showing interesting, the second thing, that as many adults have considered suicide in the last 30 days that are diagnosed with diabetes. So that puts it in perspective. We think diabetes is everywhere. There's 10.2% of adults have diabetes, but 10.7% considered suicide in the last 30 days. And it's hard to know, well, who's really going to act on that and who's not? Who's going to be the first resident who is able to cope, and who's going to be the second resident who just couldn't and nobody knew and she took her life? And that's some of what we're hoping our training can do, but it's going to take more than that. Depressive disorders, 3.5 times higher now than they were in 2018. That's really significant. In just a few years, we're looking at 24% depressive disorder. That may not be major depression, but that's enough symptoms that someone is willing to admit it, and it may be affecting their treatment, their daily life. This is a really significant, this is from the slides from Evolve MD with this change in suicidal ideation. And this is really significant that now suicidal ideation in 2020, you see on the bar on the left, 10.7% of people, adults, have considered suicide in the last 30 days compared to 2018, only 4%. And the significance here is that if you go to the right, ages 18 to 24, 25% have seriously considered suicide in the last 30 days. 16% in 25 to 44 age range. So that 1 out of 5 people between 18 and 44 have seriously considered suicide. Now, this is very different than the past. In the past, when we take our board exams in psychiatry, who is most likely to actually take their lives? It's going to be the older age groups. It's 65 to 70. But now we're look at the huge bar in our young people. And some of you know kids much more than I do, or young people, and that they don't have the perspective of life to know that we will get through this. They don't have the same coping skills. And the problem with the pandemic and the isolation, a lot of the coping skills that people have, we are created to be social beings. And although we can be social now on Zoom, it may not be quite the same. So this is very significant, and we are going to have to do something about it. This is probably from some of the similar CDC data, but this is from the Kaiser Family Foundation. And what this is showing is adults 65 and over, and this is just saying that worry or stress related to coronavirus has had a negative impact on their mental health. This is not diagnosing anything, but this is, as you know, people over 65 have more physical health issues, more issues just perhaps in their daily life, and they're the ones that may even be more isolated. The CDC report that I mentioned had some really good data about caregivers and people who are taking care of people. So we're looking almost 50% of the people over 65 admit that worry and stress is having a negative impact on their life. And the significant thing too is that these are not people that necessarily need to see a psychiatrist, even if they could get in to see one, but they need some help, and we need people trained to help them know what to do. And we've got to pay attention to this while it's early on the curve. So to jump into the psychiatrists and the shortage of psychiatrists, this 2018, you can see the gray are no psychiatrists. The bright green, or the green, eight psychiatrists per 100,000 people. So they're all over California, Arizona, and the Northeast. And if you cone in on Arkansas, there's a lot of gray in Arkansas where there are no psychiatrists in that county. There's a little bit of blue, so there may be less than 4, but there are just not enough psychiatrists. There's a shortage. Even if we could get people to go to them, there are not enough. I don't know if anybody's tried to send someone to a psychiatrist lately, but it's going to take, certainly 2 weeks, if not 2 months, to get to see someone. This is some data people are talking about. Merritt Hawkins is a recruiting company, and they put out a white paper actually in 2018 saying the psychiatry, the silent shortage. And they give some data that you can look that paper up, but saying psychiatry in 2018 and still 2019, 2020 is the second most recruited specialty. The first most recruited specialty that they're looking for physicians and nurse practitioners and PAs is family practice. But the second one that they're searching and people are trying to hire psychiatrists, it's the second highest. And that's way different from probably 2000, 2005 when it might have been 10th or 13th. According to Merritt Hawkins, there in 2018, there were 30,000 psychiatrists in the US, which is an average of 9.3 per 100,000. But you saw how most of them are located in urban areas and in certain states. Now, according to this data, there's 188 psychiatrists in Arkansas. I'm going to show you some data from the Department of Health. It's a little bit different, but this is a reliable statistic. And they're saying this is 6.26 psychiatrists per 100,000. So even if people wanted to see a psychiatrist, if they were willing to, it's hard to get in and find one. And then if they do, remember the thing that psychiatrists get paid for mostly is prescribing pills, being prescribers. Significant that 59% of the psychiatrists in the United States are over the age of 55. People, and you might have seen as healthcare has changed, a lot of physicians that can retire have retired. And the other part about this is that 50% of the psychiatrists that are out there are only taking cash, that they are not on insurance panels, that if you have, my phone is ringing, so I'm going to go turn that off. Sorry about that, because I'm on a hotspot. That it's really relevant that even if someone has insurance, that they may not get in to see psychiatry. And you're like, why would psychiatrists only take cash? And it has to do with that the reimbursement is so much lower when you're getting it from insurance. And if you're going to be super busy anyway, and you're working hard anyway, that it's just easier to do self-pay. People are busy enough, and that's across the country. And I think it probably pans out in Arkansas as well. The other thing I noticed in Arkansas is most psychiatrists have multiple jobs. They will work 2 or 3 different places. They've got a private practice, or they're on one of the inpatient units. So they're doing various things. So they're spread pretty thin. The fact that there's only across the country 1,243 psychiatry residents finish each year. So you can see it's going to be really difficult to catch up and have enough psychiatrists. That was in 2018. And I just read this week that one of the limiting factors there is that around 1997, there was legislation passed nationally that limited the number of residents of all types. So the federal government could only give so much money to residents. So that's why we're getting a progressively shortage of physicians as a whole, but including psychiatry. So there's a definite shortage of psychiatrists, even if we wanted to see them and we can get through the stigma, and that patients whose symptoms are, screened and assessed and then referred, there's still not enough psychiatrists out there. This is actually from the Arkansas Department of Health website in 2018. This is for specialists. They said there was 2,866 specialists overall. And they said that there were 467 psychiatrists in Arkansas in 2018. Thing is, this is not all practicing psychiatrists, but I thought it was really relevant that you can see the age group. Most people are finishing their residencies in late 29 to 30, early 30s. And so that that segment of the population is still fairly low, but you see how we still have 86 and 124, 44 psychiatrists are between the ages of 70 and 79. So a lot of those are not practicing, or they're practicing very little. So you can see the reality of the numbers of how many psychiatrists are in Arkansas is there's a huge shortage. And so we've got to figure out, well, how are we going to get that expertise? This is also this is from the Arkansas Department of Health. How many psychologists do we have in the state? Psychologists have a PhD or a PsyD, or they may have a master LPE or LPEI. So in Arkansas, in 2018, there were only 696 psychologists. In the purple is where they had 3.5 to 6.7. The yellow counties have no psychologists. 20 counties in Arkansas had 0 psychologists, and 16 only had 1 psychologist. Social workers, in 2018, there were 3,092 social workers. Now that includes people who just have their bachelor's and LSW, who may have their master's, 905 people. And then to be fully, got their full credentials, 1,700 LCSWs. That's only 10 per 10,000 people. So on this map, you can see the purple in Pulaski and Washington Green and Craighead. They may have 14 to 20 social workers per 10,000, but we still have two counties, Cleveland and Calhoun, have 0 social workers. And social workers are often doing a lot of the therapy, but then they're also doing a lot of other helping social determinants of health, helping people in medical settings. So these social workers are spread very thin. We don't have many mental health providers in the state at all. And it was interesting to me, and I could not find how many LPCs we have in the state. So we do know that there are some, and that they are providing mental health care and working either as independent therapists, just like some of the social workers or psychologists. But in the state of Arkansas in 2018, even if we said there was 300 LPCs, we're less than 5,000 mental health providers in the state. And that's if everybody with the license is practicing. So what are we going to do? Now, this slide is actually from Roger Cathol. He gave a talk to this talk in ABN in December. And he points out, so where are all these behavioral health folks? Where are they working? The behavioral health sector, most of the behavioral health trained people are in the behavioral health sector. 95% are there. The big blue circle is the outpatient, medical outpatient part of our care. The little white circles are inpatient. And you can see that, of course, most patients for anything are in outpatient. Those with significant chronic medical illnesses are going to go back and forth into inpatient. But only 5% of those mental health clinicians, behavioral health providers are in medical settings. So for a patient to get to a behavioral health person, they are going to have to go outside the medical setting. And this brings up probably another whole hour to talk about, is how does this care get paid for? And this is where we're running into issues with the reimbursement, the credentialing and reimbursement for mental health care in the behavioral health sector. And then when you bring those folks into the medical setting, we're having issues with credentialing and with billing and with codes and that type of thing. So behavioral health integration, we've got to bring these together, because all those patients we described, most of them are in the blue circle. And that's where we need to get the care, because it's causing significant issues with not only their health, but our function of our society. So how do we get access to mental health specialists? We got to go where the patients are. And so the first step is in primary care, but we need to redefine how to get that access. How can we increase the capacity of who's there? It's got to be more than just face-to-face visits. We need to get the patient started sooner. Look at some of the barriers, and financial sustainability is definitely one of the issues in our fee-for-service system. And then we're going to have to do it as a team. You can see there's not enough of any clinician. There's not enough primary care providers. So we're going to have to work together as a team to catch these fish, and also look at teaching people to fish and not just giving them fish. We tend to want to, once patients are identified, is to either, remember, people came down the fork in the path and they want to just put the patients over to, let's just send them into mental health. But the patients are going to stay in the medical setting mostly. I wanted to share this. We've been working hard across the country and in Arkansas to do behavioral health integration. And a lot of it is going well, but we've got more to do. And this study in 2014 is when it was published. It was in Minnesota, and they were looking at, well, what were the important things that made this behavioral health integration successful in which clinics? And the number one factor was cost not being an issue. We know that cost is an issue with some of our CPC plus clinics and other clinics who are trying to do behavioral health integration. It's how can they afford to do it, as well as afford to do the other things they're trying to do with care coordination. And the second most important factor in this was to have an engaged psychiatrist. And we know that we just gone through, there's not enough, but we're not having enough engaged psychiatrists trying to help with our behavioral health integration. A huge piece, number 3 and number 7, has to do with having a primary care provider. We've been working really hard to push out this value-based and population health. But the primary care docs and nurse practitioners, PAs, they're seeing patients one after another, and they don't have time for these meetings and trainings, but somehow they're going to have to get bought in, and that's where this is going to change and work. And in some clinics it is, but you've got to have the buy-in of the providers. Having a strong care manager, and what they're talking about is the behavioral health consultant or the person who is doing the behavioral health care part. Being able to do warm handoffs was a key. Having strong leadership, and whether that be in the clinic, in the system. So having roles defined, and then having someone accessible. So these are some of the factors, and I think we have to look at other states and other places to see what has been useful. I'm sharing this. This is an article that was published in Psychiatric Services in June of this year. And the first author, Lori Rainey, you'll see I'm down in the third author. And I'm putting this up mostly, I had a great experience getting to know some of these other people across the country who are trying to do what we're trying to do. And Lori Rainey is a psychiatrist that's in Colorado and a consultant, and has been doing just tons of teaching in behavioral health integration, the role of psychiatrists. And she was our lead author, and really, she said mostly what she's trying to do is teach how to leverage psychiatrists and how do we get them, people to be able to have access. And Mark Williams is a psychiatrist at the Mayo Clinic and is doing a lot of collaborative care. And he's not the chairman, but he is lead of a department. And so a lot of the things that we ended up publishing in this article are some of the ways that we can change the role of psychiatrists and other mental health professionals to be able to take care of all these patients that we've had, but also that are going to be flooding in as a result of the pandemic. So looking at education, looking at creating psychiatric access lines, similar to what we had some years ago, Psych TLC, providing collaboration and case review, consults, and direct care. I know this is a crazy slide, and if we were in a big auditorium, I would never show it, but since you can put your face down on your computer, I wanted to to put it up there anyway, but this is from our article. But it's, of course, Dr. Rainey really put this together, and it's so unique. I wanted you to know it's there and you can look at it, but it shows some of the, as we're trying to figure out how to leverage psychiatrists in Arkansas and across the country, a lot of people are just doing a lot of stuff. And one of the key things is figuring out the benchmark in the literature for the effectiveness. And so we need to work harder and not work smarter and not harder, but to figure out where is the evidence and where can we where can we get our maximum bang for our buck, and looking at what's the evidence. So that's an important piece, but that's not all of it. Looking at the role of the psychiatrist, and then where is the psychiatrist in these different models? Are they the backup? You can see in responsibility for follow-up care, the PCP is still maintaining responsibility in all these models. And so they have to know what they're doing, and they have to get support. And the psychiatrists, physicians are needing the support of other physicians. The last column is huge, which is it covered by insurance? And mostly you're going to see a lot of no's there, because our fee-for-service model is very much about direct care. A lot of these models are about indirect. So the different approaches in the first column is doing education. You know, we can do classes, didactic presentations. One of the points we made in this article is that most people learn from case-based learning, using cases and learning from the cases you've got day to day. The collaborative care model, using a Project Echo model, using e-consults where the doc may put in a consult and it's reviewed later. You can also do psychiatric access lines with phone consultations. This asynchronous telepsychiatry is something to consider, and this is where patients might be recorded, and then you send the video recording to the psychiatrist to give an opinion about the case without having to see the patient themselves. Psychiatrist or psychiatric nurse practitioner might just see the patient once, a one and done, as opposed to wanting to hand off the patient. Doing case reviews, and then doing some short direct patient care. So these are some of the possible ways of leveraging the expertise of the few psychiatrists that we have. So, okay, now what? How are we going to adapt, and what's next in terms of, as we're building our teams to make behavioral health integration work in the state, to really make an impact on the patients who either are already showing up in primary care, or that we're needing to get them into primary care? How are we gonna help them? The things that we have already done, and this is my last slide, and you can be thinking about if you want to make comments or type some things into the chat about, so, well, now what? What are your thoughts? Some of the things that we are already doing in Arkansas, we're trying to do these population health initiatives, CPC Plus, the Medicaid PCMH, the ACOs. We are trying to change the approach and the way care is paid for, but also the way that we're approaching the population and looking at highest needs. We are doing a good job of doing a lot of trying to implement care coordination, whether it be in the clinics, in the systems, in the hospitals, but also the various insurance payers have care coordinators, and that's a huge piece. Doing behavioral health integration, you know, just the fact that a lot of you all are doing it, or you're learning how to do it, and there's some things being done. ABIN, with y'all's support, I think that we are able to get some traction, and to be able to really bring some real useful training, and to be provide technical assistance. But where are the gaps? We still have gaps in financial sustainability of the model. the primary care docs and nurse practitioners feeling comfortable, confident, and competent in managing mental health issues. They are the de facto mental health care system in our country right now in Arkansas. We've got to get continued more buy-in and engagement from the primary care staff and PCPs and administration. Because remember, a lot of those came to the fork in the road and they said not psych. So we have to help them figure out how they can do psych at the level that's appropriate for their training, and when to use people at their highest level of their training. Providing some behavioral health clinician training so that we can look at doing behavioral health integration is not the same as doing traditional mental health. We have to do it in a different way. And then how do we get some psychiatrists involved? We are definitely not the only people who can provide behavioral health by far, but we have to be part of the team. This team is the number one word to say as we're moving forward in healthcare as a whole, but especially as we're trying to address mental and behavioral health issues. So it's your turn. I'm giving some info and some possible solutions, but also it's where do we go from now for you as an individual, but also for us as a state or for individual clinics. So I'm going to stop sharing now and feel free to put your cameras on or not, type in things, or let's have some conversation.
Hi, this is Joshheimberg. I work with Arkansas Children's Care Network. And one of the obstacles we have with the pediatric population is the actual policies. The Medicaid policies, when they created the PASS systems, and they were hoping to create, I think, outpatient behavioral health services, put out a separate manual, but it's still relatively restrictive and burdensome for small practices to figure out. It's a whole new system. Instead of being able to just drop a charge to Medicaid like you would a physician bill, you've got to figure out a whole new billing system, a whole new level of credentialing for providers. And it's so complicated that I don't think a lot of practices feel comfortable taking it on. So I think one of the issues to us getting better integration in primary care is kind of addressing that policy side of things. And I think Medicaid would be willing to work with us. Especially if you had multiple voices coming and saying, hey, can we do things to improve? The intent was there, but the policy is restrictive.
Wow, Josh, that is really well spoken, that Medicaid and the people that are in our state and other states, they have the right intent. But just like a lot of things, it starts in Washington, or it starts at the top of a hospital or the top of a clinic. It's a great idea. But what happens in the day in and day out in the trenches, it often doesn't get translated where it needs to be. So definitely, I think communication and us working together and policy change is needed. One of the huge programs, Colorado has a SIM, S-I-M, huge program that they did for 5 years, $65 million. They had Medicaid involved. They had all these practices. And so as I was getting ready for this, I looked up, wonder what they found from SIM, Colorado SIM. And I was also trying to get some info for financial sustainability. And what I'll just say, I emailed Dr. Rainey. I said, what did they find? She said, well, they found a lot of different people, did a lot of good stuff. But at the end of the day, even though they had all these people at meetings, they could not agree on what was going to be the best way. Medicaid said one thing, the commercial payers said another. But everybody getting on the same page, I think, is important. So I don't have the answer, but I know that we're going to have to work together and bringing forward the voices like you're saying here, and policy is part of it. Advocacy is part of it. I appreciate your articulateness on that issue. Let's see. So we've got some comments. Somebody said, I'm finding decreased access to therapists who accept Medicaid and our kids. So it seems like, and this kind of may fit right in with what Josh is saying, that instead of more access, we're seeing like we're getting less access. Someone else says they agree. Individuals with Medicaid create an increased time to help them find accepting services, that it's getting sad, and oftentimes the patients are giving up because it's so hard. It should have been easier. And even the past systems, they have care coordinators trying to help people navigate, but it's not working. Somebody asked me, what do I feel as family practice providers can do once depression and anxiety is recognized before prescribing a pill? So I'm a huge proponent that I can prescribe, but it's probably the least effective tool. If you even look at the research, only 65% of the people who ever get prescribed medicine reach remission. And most of those are only going to get a little bit better. So it gets back to some of the basics of how do we help overall healthcare. The basics of what are you eating, what are you doing, who are you hanging out with, the nutrition, the exercise, the healthy living. But the other thing is therapy, and it can be formal therapy, but it can also be various self-help type of activities, lifestyle, these types of things. And unfortunately, family practice primary care docs are taught mostly pills and tests and interventions that, and it's because we don't get paid to tell people that they should go hang out with their friends or that they should go exercise or walk. What else? Any other comments? You can see I can talk for days, and this is important, but I think I want to just get this aspect that we start seeing what are the other pieces to this. How can we get some solutions?
Dr. Gibson, this is Jennifer. Do you feel like because of the shortage in the workforce, that we really have to look at how we reimagine, restructure workforce to be able to spread out the capabilities, whether it's using telehealth and other kinds of techniques or strategies. And also there's, because you have to reimagine the workforce, you have to also do upskilling of their training in different ways, such as lifestyle change with the health, with primary care or medical, which I think we have been in these specialty boxes for such a long time. There's not enough cross-pollination of training that would really help physicians, primary care physicians, on mental health diagnosis and treatment, and vice versa, primary care with mental health or substance use.
Yeah, totally. And in a way, this is the worst of times with this pandemic, but it's also the best of times in that we have the ability to, here we are all on this call, and we have the ability to use technology and telehealth, so we can really exponentially do more because of the, using a few providers, whether they be psychiatrists, psychologists, therapists, as well as dietitians and other types of folks. But yeah, I think we're needing to come together and create a system that can provide support, but then also continue to provide training and helping everyone practice to the highest level of what their license is. So I see it as a combination of training, restructuring, adding some support, perhaps virtually. I really like the idea of being able to have a support, creating a mental health access line where we could provide kind of a network of support virtually.
Dr. Gibson, I think that that's such a great point. I was going to piggyback too. I think the other part of training is to help behavioral health practitioners become comfortable with more of a 15 or 20-minute visit, not doing a 50-minute session for everything, and really supporting the team and seeing that team or primary care team as their primary client in some ways to really enhance the work that the whole team is doing. And I think that that is a big hump for training. And then the other part is I find sometimes working with practices, helping them actually know how to find the right fit for a behavioral health practitioner, that personality type that works well in primary care, and how to recruit. Because I find that there's a big difference in how people are recruiting and then what they get, and then it feels like they can't find a practitioner, but there's actually a lot out there. They either don't know where to find them or how to recruit for them.
And that's a huge point, that where those of us that were practicing in specialty or traditional mental health, that is needed, but it's not the same. It's kind of like taking a pulmonary specialist and having them go to the primary care clinic, and it's a different way of approaching. So we definitely need more training for behavioral health clinicians of how to practice differently, to how to be in that primary care culture, which primary care docs are going to see people for a few minutes and they have to make a lot of decisions on the fly, and they're going to do stuff over time as opposed to long visits where you can't get interrupted. So there's a huge place and need for training for everyone, for the behavioral health folks, for the psychiatrists, but also for the primary care docs, the primary care nurses, so that they can work together and do those on the fly consultations. So thanks for bringing that up, Wendy. And I know you've been helping us a lot in trying to create training opportunities in Arkansas. And we will continue to do that. But it's being aware of the need and that there is something that's there. So thanks for bringing that up. I know it's 9:01 and people are having to start. They're saying goodbye and having to get off. So I really appreciate your being on here. Yes, we will have the slides available. We have our new website updated, www.abinnetwork.com. And the slides are on there, and also Kim will send them out. So it's ABINNETWORK, ABIN Network.
.org.
.org. Yeah.
Yes.
Appreciate everybody getting on. I appreciate the comments, and this is such needed, and I'm glad to have all the different aspects.
Dr. Gibson, thank you so much for taking the time today to share this knowledge with us. We really appreciate you and sharing your expertise. This is such an important topic. You know, one of the things that I think about and just wanted to put out there, I heard at CFHA last year, this is cutting edge. This is cutting edge work. And in doing cutting edge work, there's cuts. And so for us, we have to be thick-skinned, and we have to know we're the trailblazers for this model, and this may be difficult. However, working together as a team and supporting each other in this team approach, we're going to be able to continue to move forward. So,
definitely. Thanks, Kim.
Thank you for your time today. Thank you, everyone, for joining us.
Thank you. Y'all take care.
Bye.